Thanks, everyone. This is Faraidoon. First of all, I really love to be there. And that's one of my dreams to one day come there, have a presentation from like in person there. I love it, but situation has been difficult traveling these days, but hopefully very soon you will see me there in one of the meetings. I'm Faraidoon. I'm originally from Iran. At the moment, I'm a general practitioner from Iran. At the moment, I'm in Australia, Sydney. I'm a full-time research fellow in headache disorders, conjoint lecturer for University of New South Wales. I'm also a part of the editorial board of Cephalalgia, the official journal of International Headache Society. Today, I wanted to talk about the blood pressure medications for the management of headache disorders. I'm not gonna talk about the guidelines because I'm sure everyone knows what medications are mentioned there. I will talk about them a bit, but my main goal is to talk about the research that currently is happening and what we think should be added to the guidelines. And hopefully in a few years, we can see some changes in guidelines. So migraine management, we use medications and non-pharmacological ways. For non-pharmacological ways, some of them were mentioned. It's not about, it's not the talk today. So we have a paper. At the end, I will provide my contact details. If you email me or message me, I can share all the documents or anything that you feel like is interesting. So this paper that we have published, we have collected all non-pharmacological ways for management of migraine. So for drug, we have acute and preventive treatments. For acute, we have specific and non-specific treatments for acute treatment of migraine. Non-specific means that the ways that were mentioned, like NSAIDs, paracetamol, or any painkiller that we use for other things, we can also use for migraine. But specific, they also mentioned that, like for example, triptans. So triptans were that important. It is called one of the era of headache research. So if you know this lady Rigmor from Danish Headache Center, she was presenting, and these are in one of the international headache conferences. So we have technically three main eras for headache research. The first one is 1988, when we had the introduction of International Classification of Headache Disorders. Then 1990, where the triptans were introduced, and it was the first migraine-specific acute treatment that we had. And it took us about 30 years, and us, I mean them, because I was born in 1988. So it took people like researchers over 30 years, about 30 years, to find the first migraine-specific preventive treatment. So the thing that I love about research is it's so good to be part of this amazing line of changes. Like I see like all of these people who made these changes, including Rigmor, are like my role models, and I always love to talk to them. And somehow that's why I stopped clinic and I decided to join research forever, like as a full-time, to be part of these changes. So for prevention, we have the same thing, specific and non-specific. Specific, as I mentioned, it is anti-CGRP medications that were introduced recently. So we have a review published in Cephalalgia. We checked all of these medications, anti-CGRP medications. So clearly we found that all of them are useful, safe, effective, and should be used. For non-specific, which is the topic of this talk, we have blood pressure medications. This is another review we published in Cephalalgia. So first of all CGRP medications, we found them that they are very useful and very effective. In this review, the second one, we also found the same thing for blood pressure medications. We found that almost all blood pressure medications are useful in prevention of migraine. The other thing is CGRP medications are technically one of the best medications available, especially for people who didn't respond to any other treatments, had chronic migraine or refractory migraine. But if we look at the average, like let's say average general population of people with migraine, what we found for anti-CGRP medications was they reduce about 1.5 to 2 days in 1 month. The same thing we found for blood pressure medication. The other thing that is important is availability. So yes, CGRP medications are important, but we don't have them in Iran. I don't know about Pakistan. In Iran, these medications are not available. In countries that are available, like Australia, they are only for people with chronic migraine, more than 15 days of headache, not responding to other treatments. Otherwise, insurance is not accepting it and they have to pay out of pocket, which can be very expensive, from 300, 400 Australian dollar to $1,000. So that's why we believe that we should focus still on non-specific migraine medications, which are available everywhere we can use them and we can repurpose them. So this is some results from the paper that was published in Cephalology. We found that all different classes reduced different types of headache, like headache days, headache attacks, migraine days in people with migraine. And this is every specific medications, which I'm not going to talk about every single one of them. I can share this data later. So what we want to propose is, yes, in guidelines, we have some of these medications, but how about the others? Maybe we can have more of them in the guidelines, prepare them and provide them for people, especially GPs and neurologists, to use more medications for treatment of migraine, not just a specific list of them. We did another study. This one has not been published yet, with a team in Canada. So we included all interventions on migraine. And the design is a network meta-analysis, which means that in network meta-analysis, you can compare medications and interventions that have not been compared in actual trials. For example, if a trial has compared A and B and another one has compared B and C, so with network, you can compare A and C that have not been studied in one single trial. So we included 188 randomized clinical trials to compare every single different interventions that are available for migraine. And the result was really interesting. What we found that 2 of the interventions were the most effective, and in terms of safety, the safest ones: beta blockers and CGRP antagonists. So this has some limitations. Clearly, we have put all medications together. We have compared classes, not single medications, but we have done subgroup analysis and more analysis. This study will be published soon, hopefully. So what we found is CGRP medications are amazing, but beta blockers are also good, and they are also safe. So this is another evidence that blood pressure medications can be actually still be considered for treatment of migraine, especially in the context that we don't have other medications. Here is the guideline. I'm not going to go specifically, but still in the guidelines, what we have is, as the first line, we have beta blockers. Then we have candesartan among the treatments of, among the suggested treatments for migraine. So clearly you have to check the side effects, contraindications, for example, pregnancy, asthma, and other disorders to select the best treatment. And also sometimes you have a patient with migraine that has also high blood pressure. So it's better to treat the patient with the medication that treats both disorders. Then here in this guideline, which is 2021, we have CGRP medications as the third line medications. But guidelines like American Headache Society guideline, European Headache Federation, they are suggesting that these medications, anti-CGRP medications, should come to the first line and be available as a first line medications. So this is a guideline by International Headache Society, published in Cephalology, which here it's not about first line, second line. It's about the quality of evidence, strengths of evidence, which is based on the sample size of studies, study design, and things like that, which we see that rimegepant and eptinezumab, which are the anti-CGRP medications, had received a moderate level. And then after that, candesartan, propranolol, which this is mostly because of the sample size and the study design. Here, you can, if you scan this QR code, you can download this guideline. This guideline has 2 versions. One of them is a long version, which everything is explained in details. But the second one is a very short summary, which is very easy to use. Yeah, so this was about migraine. So now the question is that we are working on this topic specifically. I'm very interested in this topic is, okay, we have beta blockers, candesart, and some medications in guidelines for management of migraine. And also we believe that almost all of them work for migraine. Then how about tension type headache? Do we use them for management? Do we use blood pressure medications for tension type headache? So the question based on the guidelines at the moment is no. Like, we don't have it in the guidelines. This is one guideline published 2021. This is another one. In none of them, blood pressure medications are recommended for treatment of tension type headache. But what we believe, and hopefully we can make a difference and change in the future, is first of all, why it's not recommended. Its answer is simple. There is no trial. So if you search for trials on blood pressure medications for tension type headache, you cannot find any. There is only one study, which is blood pressure medication on top of another medication compared to that medication. And it's not about technically blood pressure medications purely. But there is no study. And when there is no study, then there is no, we don't mention them in the guidelines. So here is clearly a huge gap in science. And we believe that this is the best area if someone wants to design trial. If you want to design trial, if you have capacity, potentials, and funding, studying blood pressure medications for tension type headache is, I think, will be the real helpful thing. And I will say, give more information now why we believe that it should be studied, and we are planning to study that in future. So we did another network meta-analysis. As I said, we couldn't find any study that has used blood pressure medications for prevention of tension headache. But what we did, we included all randomized clinical trials that have used blood pressure medications for treatment of blood pressure, but they have reported headache somewhere in the study. For example, in the side effect table, in the results section, they have reported the effect of these interventions on headache. So we found 424 randomized double-blind trials on blood pressure medications for treatment of blood pressure that headache was reported somewhere in the study. And this is the result. This is also, it has not been published yet. We are preparing it and hopefully it will be submitted in a few weeks, maybe a few months. So what we found that almost all blood pressure medications reduce headache. We don't know if it's tension type headache or migraine. We know that it's headache and it reduces headache, but we somehow, based on the prevalence of these disorders, we believe that a high amount of these might be tension type headache, and still the blood pressure medications might have the same effect on tension type headache. And an interesting thing is, if you look at the drug labels for blood pressure medications, in almost all of them, headache has been reported as a side effect. So our first goal is to revise drug labels and tell them that I think we should remove headache as a side effect of blood pressure medications. It is actually preventing them. The second one is we hope we can design studies on tension type headache, blood pressure medications on tension type headache, and add blood pressure medications to guidelines for tension type headache if we can prove that it's effective in a trial specifically on tension type headache. Here, if you look at this is how we scored the effect of these different interventions compared to each other.
Dr. Faraidoon, kindly display full screen because these slides are a bit difficult for us to see here.
Sorry about that. So now do you see the full screen now? Yes?
Yes, it's easily visible now.
Sorry, sorry about that. Yeah, so here we are comparing different classes, not different medications, different classes in terms of reducing headache, the risk of headache. So we see that placebo is the red one at the end on the right side, and the green one is the best. What we found that almost all classes are useful. That's one finding. Second, we found that combinations, like mixing of different blood pressure medications together, is actually better than monotherapy using only one class. And the last one is we found that calcium channel blockers were in a monotherapy like use, single use, were actually less effective compared to other classes. But when it's combined with other classes, it has a good effect. This can be because of the nature of the medications, or it can be just because of the type of trials that we have included. And yeah, we have explained this more in the study that when it's published, we will share it. This is for every single medication. Not every single, it's like the 5 most used medications in each class. And again, you see that almost all of them are useful. Again, for calcium channel blockers, there are some exceptions. Nifedipine, based on this data that we have, almost increased the risk of headache. The rest were like sometimes, some of them not significant. Amlodipine was significantly reducing the risk of headache, but the rest, many of them were useful in prevention of headache, and this is just the monotherapies. So we were thinking, what's the reason for this? Maybe reducing blood pressure is the reason that headache is reduced, because some previous reviews suggested that the only common effect of all of these medications is reducing blood pressure. Maybe that is the reason. So what we found was, yes, somehow reducing blood pressure reduces headache. The trend was there, but it was not very convincing. Like statistically, it was significant, but it was not very convincing in terms of like the actual numbers. So it will like, and the graphs that you see. So it was like, we think it has effect, but it's not the main reason. And we hope we can answer this question in future research. So one of our goals in Australia that we are looking for funding is to study blood pressure medications for tension headache. There is a polypill, a mix of 3 blood pressure medications in Australia, which has telmisartan, amlodipine, and indapamide. We want to study this polypill for prevention of tension type headache. We are trying to get fundings. Designing trials in Australia is super expensive. And without proper funding, having a study is almost impossible. So we are still in the process, but hopefully we can do this in the future. But if you have the capacity and you like to design trials, I think designing a trial on blood pressure medications for tension headache makes sense and is like a gap. And I would be happy to help if anyone that is in the process of designing and performing it, if you needed any help, I would be happy to help if possible. And the last one, cluster headache. So how about cluster headache? Do we have blood pressure medications for cluster headache? So what we have in the guidelines, and it was mentioned before, verapamil is the first line treatment for cluster headache, for prevention of cluster headache. But as it was mentioned, almost more than half of the people with cluster headache, we had a survey in Australia, the result was the same. They believe that it is not effective that much, like 50%, 40%, something like that, actually benefit from that. And it's not like a miracle. I don't know what your experience is. And even this verapamil study, this verapamil as a first-line treatment is only based on 1 randomized clinical trial compared to placebo. And the whole study was about 30, 40 participants. So it's a small study. Generally, we don't have big trials on cluster headache for many reasons, because of the disease is rare, the nature of the disease, that sometimes in a few months they have headaches and then the rest of the year no headache. So including them is difficult, and many other things. Funding, no pharma company usually is interested in funding cluster headache because it doesn't bring back value, like interest at the end. Clearly, governments, it's difficult to convince them to fund studies on cluster headache, maybe for many different reasons. We don't have that many studies on cluster headache, but here we see that verapamil is the first line, but we have other medications. Galcanezumab recently for episodic cluster headache was suggested. This is a study that a headache research center in Norway called NORHED, with the help of other countries, including Denmark, Danish Headache Center, they went to do this study, candesartan for cluster headache. It is funded and they will start very soon. in Australia, we are trying to also get funding and join as a site to help with this study. This is also, I believe, super interesting study for cluster headache, especially if we do it properly with good sample size and good power. Then maybe we can show that more blood pressure medications can be used for treatment of cluster headache and be added to the guidelines. So generally, I believe that blood pressure medications are useful in prevention of headache in different types of headache disorders. We need to study them more. We need to provide more evidence and add more of them to the guidelines, especially for tension type headache, that we have no treatment, no blood pressure medication for prevention of tension type headache. So in summary, blood pressure lowering medications reduce headache. We have evidence for that, and now it's very soon it's gonna be, it's like a fact. Then for prevention for migraine, at the moment in the guidelines, we have, based on different guidelines, it can be different, but it's mostly beta blockers and candesartan, but we have lisinopril and others in different guidelines. For tension type headache, at the moment, nothing is suggested. And for cluster headache, we have verapamil. Thanks, everyone. I tried to be quick and not to give a lot of
Thank you, Dr.
slides and
Faraidoon.
things. Yeah.
Thank you,
This
Dr.
is my QR code. If you like to contact me, you can scan this and you can find information about it. Thanks.